Hi guys, welcome to Podcast Med. The topic of discussion in this podcast is diseases of external ear. We all know external ear is divided into three parts, that is pinna, external auditory canal, and tympanic membrane. Coming to the diseases of pinna, before going to disease of pinna, we'll discuss about what does normal pinna look like. Normal pinna is of height 6 centimeters and width of about 55% of its height. That is, width of the pinna is 55% of its height. Then coming to the angle it makes with the face, it is protruded by 15 to 30 degrees normally, and if it is more than 30 degrees, then the ear is a protruded or prominent ear. Coming to the vertical axis setback, it is about 20 degrees. Then we'll go with the different parts of pinna. Please refer to a diagram which shows the parts of pinna rather than listening to this, because it might be confusing. So I'll just read out the parts that are present in external ear, that is external pinna. The parts are helix, antihelix, scaphoid fossa or triangular fossa, tragus, lobule, cavum concae, crus of helix, symba conca. Basically helix, antihelix and crus of helix. These three parts, you have to remember it like this. And there are two depressions which are triangular fossa and symba conca or cavum conca. Okay. Then coming to tragus and antitragus. Then one more is lobule. Remember it like that. Then coming to the disorders of pinna, we have congenital abnormalities, trauma to the auricle, inflammatory disorders, etc., tumors. So this disorder of pinna are divided into these three: congenital abnormalities, trauma to the auricle, inflammatory disorders. Coming to the congenital abnormalities, there can be, these are the names that are described here, which are anosia, microtia, macrotia, bat ear or protruding ear, cup ear or lop ear, cryptotia, coloboma. Minor deformities like Darwin's tubercle, Stahl's ear, Sathier's ear, deformities of the ear lobule, preauricular tags or appendages, preauricular pit or sinuses, etc. These are the congenital abnormalities of pinna that are described here. We'll go one by one. Coming to the anosia is absence of pinna and lobule, and usually it is a part of first arch syndrome, developmental abnormality from the embryological stage itself. Then we have microtia. Microtia is small pinna. Basically, it is normally associated with the other anomalies like other anomalies of external auditory canal, middle ear and internal ear. And this can be both unilateral, bilateral, and hearing loss can be seen sometimes in this. And the ear in this microtia is of peanut ear. Peanut is a form of microtia. Peanut ear is a form of microtia. There can be macrotia as well, like large pinna. Then coming to the bat ear, or it can also be called as prominent ear or protruding ear. This is abnormally protruding ear where the angle of protrusion is more than 30 degrees, which is more than normal. And then coming to the cup ear, this bat ear we have will normally see seen in the actor Aamir Khan. Then coming to the cup ear or lop ear, there is ear that is hidden or buried. The ear is actually hidden or buried. It is because of the hypoplasia of the upper third of the auricle, basically. And the upper portion of the helix or pinna is cupped, and a conch shell ear or snail ear has greater deformities of cup ear. These also have deformities of cup ear. Okay. Then coming to the cryptotia or pocket ear, the upper third of the auricle is embedded under the scalp skin in this. And coming to the coloboma, it is a transverse cleft in the pinna in the middle, basically. And coming to the other normal minor deformities, we have Darwin's tubercle, which represents the apex of pinna of the lower animals. A pointed tubercle will be there. And in Stahl's ear, it is helix is flat and upper crust of antihelix is duplicated and reaches the rim of helix. It is basically kind of just try to imagine or search for a picture of it. Then coming to the satyrs here, it is a horse-like ears basically. And then coming to the deformities of lobule, there can be absence of lobule, large lobule or bifid lobule, or attached fixed lobule, which is attached to the jaw or the skin. And coming to the preauricular tags or appendages, it contains small pieces of cartilage in it. It appear on a line drawn from. They normally appear on a line drawn from tragus to the angle of mouth, and then we'll go with the preauricular pit or sinus. This is because of the appendages that were there actually, and it also appears in front of the crusts of helix or above the tragus normally. Preauricular sinus is an epithelial tract and is due to an incomplete fusion of tubercles. It may get repeatedly infected and cause purulent discharge also in this, and there can even be formation of abscess, and for that the treatment is surgical excision. Then going to the trauma of auricle, we have hematoma of auricle. This here hematoma of auricle, where the blood is collected in between auricular cartilage and its perichondrium. So this results from the blunt trauma, which can be most commonly seen in boxers, wrestlers, or rugby players. And this kind of ear formed after this stress from the environment is cauliflower ear or pugilistic or boxer's ear. So it is treated by aspiration of the hematoma or pressure dressing. Coming to the lacerations, there can be lacerations also, and we should be careful about the avascular necrosis that takes place in this. And there can be avulsion of pinna as well, but it can be reconstructed, reimplanted in the selected cases by a few microvascular techniques. Then going with the frostbite. The features in this are erythema, edema, bulle formation, necrosis of skin, etc., and subcutaneous tissue, and complete necrosis with loss of affected part also can be there. The treatment is by rewarming with moist cotton pledgets at about temperature of 38 to 42 degrees Celsius, and then we can even apply 0.5% silver nitrate soaks for superficial infections if there is any infection. Silver nitrate, 0.5% silver nitrate, and we can apply analgesics for pain. We should protect the bulle from rupture if there are any bulle formed in that, and we can do surgical debridement within several not within several months. We should wait for several months as the true demarcation between dead and living tissue appears a little late. And we can even use systemic antibiotics for deep infection. Then we see keloids of auricle as well. Then the treatment can be surgical excision. To prevent recurrence of the keloid, we can do it by pre and post-operative radiation with 600 to 800 rad in 4 different doses. Okay, some prefer local injection of steroid after excision as well. If you inject locally steroid, that can also prevent the recurrence of keloid. Then coming to the inflammatory disorders, we have erysipelas. Erysipelas is a dermal infection. Totally we have erysipelas, cellulitis, perichondritis, relapsing polychondritis, chondrodermatitis nodularis chronica helicis. Okay, these are the 5 conditions that were given here. Firstly, coming to the erysipelas, it is a dermal infection with beta hemolytic streptococci. Okay, and it is treated by amoxicillin and or amoxicillin with clavulanic acid, which normally comes like clavum, like that. Then coming to the cellulitis, it is subcutaneous tissue infection with the Staphylococcus. Erysipelas is of beta hemolytic streptococci. Cellulitis is subcutaneous tissue with Staphylococcus. That is with dermal infection. That is the dermal infection. Then coming to the polychondritis, this is infection that is secondary to lacerations, hematomas, surgical incisions, etc. It is mainly due to Pseudomonas and mixed flora that are common pathogens, and it is treated by 4% aluminum acetate and other systemic antibiotics. Then coming to the relapsing polychondritis, it is a rare autoimmune disorder. The external ear canal becomes stenotic, and it is treated by systemic steroids. Coming to the chondrodermatitis nodularis chronica helicis. This is small painful nodules appearing near the free border of helix in mostly men about of age 50 years. These nodules are normally tender, and the patient will not be able to sleep on the affected side. Okay, it is treated by excision, and it is treated by excision of the nodule with its skin and cartilage. You should treat it by that. Then coming to the tumors of the auricle, we have benign tumors in this and malignant tumors in as well. The different tumors of external ear, I'll be discussing all the tumors of external ear here. From firstly coming to the pinna. The benign tumors in pinna include preauricular cyst or sinus, sebaceous cyst, dermoid cyst, keloid, hemangioma, papilloma, cutaneous horn, keratoacanthoma, neurofibroma. Coming to the malignant pinna disorder tumors, we have squamous cell carcinoma, basal cell carcinoma, and melanoma. Coming to the benign tumors of external ear canal, that is external auditory canal, we have osteoma, exostosis, ceruminoma, sebaceous adenoma, papilloma. Coming to the malignant, we have squamous cell carcinoma, basal cell carcinoma, adenocarcinoma. We have malignant ceruminoma and melanoma. Coming to the benign tumors, I'll discuss the terms one by one. Coming to the preauricular sinus or cyst, this results from faulty union of hillocks of first. There is a faulty union in the first and second branchial arch hillocks during the development of pinna. This develops because of that. Then coming to the sebaceous cyst, it is most commonly present at the post-auricular sulcus or below and behind the ear lobule. It is treated by total surgical excision. And coming to the dermoid cyst, it is most commonly seen over the upper part of mastoid behind the pinna. Then coming to the keloid, as we have already discussed about it. Then we'll go with hemangiomas. There are two types of hemangiomas, capillary and cavernous hemangioma. Capillary hemangioma can be presented as a port vein stain. It does not regress spontaneously. Cavernous hemangioma is also called strawberry tumor. It normally regresses or may completely disappear by 50th year of life. Then coming to the papilloma, which is also called wart, it is a tufted growth of flat grey plaque and is rough to feel. It is tufted growth of flat grey plaque and rough. It is normally viral in origin. Then coming to the cutaneous horn, it is a form of papilloma as well. And keratoacanthoma is a benign tumor clinically resembling a malignant one. Normally it looks like a malignant one, but it is benign. It normally presents as raised nodule with a central crater. Initially it grows very rapidly, but slowly it regresses, leaving a scar. It is treated by excision. It is treated by excision biopsy. Then coming to the neurofibroma, it normally presents as non-tender-form swelling and may be associated with von Recklinghausen disease. It is treated by surgical excision as well. Then coming to the malignant tumors now, we have squamous cell carcinoma. It presents as painless nodule or ulcer with raised everted edges and indurated base. It presents a painless nodule or ulcer with raised everted edges and indurated base, and it is most commonly present in helix region, and it is treated in two ways. If there is no nodal metastasis, it can be excised locally with 1 centimeter of healthy area around it. If there is nodal metastasis, then it may require total amputation of the pinna. Okay. Then coming to the basal cell carcinoma, the common sites of basal cell carcinoma are helix and tragus, and it presents as a nodule with central crust. Removal of that central crust will cause bleeding, and it is treated in two ways again. If it is not involving cartilage, and then it can be irradiated. If it is involving cartilage, it might need surgical excision. Coming to the melanoma, it can occur anywhere over the auricle, and it is most commonly seen in men of lighter complexion who are exposed to sun. The melanoma is treated by two ways again. If the superficial melanoma, which is less than 1 centimeter, it is treated by wedge resection and primary closure. If the superficial melanoma larger than 1 centimeter, then it is treated by resection of pinna, parotidectomy, and radical neck dissection. Coming to the tumors of external auditory canal, those are benign and malignant tumors of pinna. Now coming to the tumors of external auditory canal, we have benign tumors and malignant tumors again. Coming to the osteoma, it normally arises from the cancellous bone, and it is a single smooth bony hard pedunculated tumor. Often it arises from the posterior wall of osseous meatus near its outer end. Okay. Then coming to the exostosis, this is just multiple and bilateral. Often it presents a smooth sessile bony swelling. It is bony swelling basically in the deeper part of the meatus near the tympanic membrane. It is normally seen in people who get exposed to cold water, more like divers and swimmers. It is treated by if it is small and asymptomatic, no treatment is necessary. If it is large, then high-speed drill to restore normal size of meatus is done. High-speed drill is done for larger ones. Coming to the cerumenoma, it is a tumor of modified sweat gland which secretes cerumen. Okay, the treatment of it is surgical excision. Coming to the sebaceous adenoma, it is similar to cerumenoma. It arises from the sebaceous glands of meatus and it normally presents a smooth skin covered swelling in the outer meatus. This treatment for this is surgical excision as well. Then others are papillomas in benign tumors of external auditory canal. It is as like as in pinna only. And then coming to malignant tumors, we have squamous cell carcinoma, basal cell carcinoma, malignant cerumenoma, and malignant melanoma. Malignant melanoma normally is very rare. Coming to the squamous cell carcinoma, it may arise primarily from the meatus or secondary extension from the middle ear carcinomas. It presents as blood staining of hithertomycopurulent or purulent discharge, and severe earache might be there. And the regional lymph nodes which are affected are preauricular, postauricular, infraauricular, and upper deep cervical. Coming to the basal cell carcinoma and adenocarcinoma, these both are same as we have discussed, and diagnosis is made only on biopsy, and that finishes the tumors of both external auditory canal and pinna. Now coming back to the diseases of external auditory canal. So let me repeat it again. We have discussed about the diseases of external we are discussing about the diseases of external ear basically. In that we have discussed about diseases of pinna and tumors of pinna separately. Okay, all of those are finished. While explaining tumors of pinna only, we have also discussed about tumors of external auditory canal. That finishes the tumors of external auditory canal there, but still there are diseases of external auditory canal here. So the diseases of external auditory canal are these types, okay? Congenital disorders, trauma, inflammation, tumors, and miscellaneous conditions. Tumors in this we have discussed already. Coming to the congenital disorders, there can be atresia of external canal. It is because of the failure of canalization of ectodermal core that fills the dorsal part of first branchial arch. Okay, it might be in association with microtia sometimes. Then coming to the pleural fistula, this is abnormality of first branchial arch. The fistula has two openings basically. It opens below the mandible, and one more opening is at the external or middle ear. So the treatment of this is excision through parodontectomy incision. Okay. Then coming to the trauma of ear canal, there can be two types of lacerations because of trauma to ear canal, that are minor laceration, major laceration. Minor laceration can be because of the Q-tip injury, where injury is because of hairpins, like scratching the ear with the hairpins, needles, matchstick, etc. And major lacerations is because of gunshot wounds, automobile accidents, etc. Now coming to the inflammations of ear canal. Inflammations of ear canal are divided into two groups basically, infective group and reactive group. Under infective group we have viral, bacterial and fungal infections. Under reactive group we have three more like that. So I'll name them one by one. Under infective group, under viral, we have herpes zoster oticus and otitis externa hemorrhagica. Under bacterial, we have furunculosis, diffuse otitis externa, malignant otitis externa. Furuncle is also called localized otitis externa. Coming to the fungal, we have otomycosis. Then after infective group, we have reactive group. Under reactive group, we have three conditions: eczematous otitis externa, seborrheic otitis externa, neurodermatitis. Coming to the viral, that is otitis externa hemorrhagica, there are hemorrhagic bullae seen, which are of viral origin. It may be seen in influenza epidemics like that, and there can be a chance of bloodstain discharge in this. Then coming to the herpes zoster oticus, there are vesicles on the tympanic membrane, meatal skin, concha, postauricular groove. It might also affect 7th and 8th cranial nerves. Then coming to the furunculosis and bacterial infections, it is localized acute otitis externa. It is because of the staphylococcal infection of hair follicle. And it is normally that furuncle which is formed is normally confined to the cartilaginous part. If the furuncle of the posterior meatal wall causes, if there is furunculosis of posterior meatal wall, it causes edema over the mastoid with obliteration of retroauricular groove. Coming to the treatment, only this you remember, just the one specific thing is there in this, that is 10% ichthymol glycerin. This is the specific one used for this. Then after this we have diffuse otitis externa, and it is diffuse inflammation of meatal skin, which may spread to pinna, epidermal layer of spread from pinna to epidermal layer of tympanic membrane. The causes of this can be hot and humid climate, and also it is common in swimmers. It is because of pH of the meatal skin. If it is changed from acidic to alkaline, it favors the growth of pathogens. The two factors responsible for this condition is trauma to the meatal skin, first one. Second one is invasion of pathogenic organisms. Common organisms which infect are Staphylococcus aureus, Pseudomonas pyosinus, Bacillus proteus, E. coli. And then coming to the phases in diffuse otitis externa, we have two phases, acute phase and chronic phase. In acute phase, we have a hot burning sensation in the ear, followed by pain, which is aggravated by movements of jaw. And there is oozing of thin serous discharge, which later becomes thick and purulent. Coming to the chronic phase, it is characterized by irritation and strong desire to itch. When we itch on it, when we scratch or itch the ear, then it can lead to other secondary infections. Rarely, the skin may also become hypertrophic, leading to meatal stenosis. This is called chronic stenotic otitis externa. The treatment is done in two phases. If the condition is in the acute phase still, it is treated in a specific way. If it is in chronic phase, it is treated in the other way. Coming to the acute phase treatment, we do ear toilet or oral toilet in this. Then we also use medicated wicks, which are soaked in antibiotic steroid preparation, and we can also use a few steroid drops to relieve edema, erythema, and prevent itching. And basically, this medicated wicks, which are soaked in antibiotic steroid preparation, we insert it in the ear canal of the patient and ask him to keep it moist by instilling same drops twice or thrice a day. So wick is changed 2 to 3 days when it is substituted by ear drops. For 2 to 3 days you'll use this, then that is substituted by ear drops. We can also use mild astringents like aluminum acetate, which is 8%, and silver nitrate, which is 3%. We can also use antibiotics, broad spectrum antibiotics like broad spectrum antibiotics. We can also use analgesics for relief of pain. Coming to the chronic phase, its treatment aims at reduction of meatal swelling, basically. So that after meatal swelling gets reduced, ear toilet can be effectively done, and we also see for alleviation of itching, decrease in itching, and further recurrences will be stopped because of that. Then coming to the next treatment in chronic phase, we also use 10% ecthamol glycerin here, like we used it in the furunculosis. It reduces the swelling. And coming to the malignant otitis externa, it is mainly caused by Pseudomonas infection in elderly diabetics or in those on immunosuppressive drugs or who has immunosuppressed condition in their body. It presents as excruciating pain, and it is normally very resembling to diffuse otitis externa, but there is excruciating pain, and there is appearance of granulations in the ear canal. Granulation tissue will be present, and facial paralysis is common in this. So it is diagnosed based on severe otalgia, which is present in elderly diabetic patient with granulation tissue in the external ear canal at its cartilaginous bony junction. Those granulations are normally present at cartilaginous bony junctions. Then two things that we use in this diagnosis are gallium-67, technetium-99. Okay, gallium-67, it is taken up by the monocytes and the reticuloendothelial cells normally when it is given. So it is an indicator of soft tissue infection. Okay, then coming to the technetium-99, technetium-99 bone scan, it will reveal bone infection. Okay, it is treated by control of diabetes, oral toilet of ear canal, and antibiotic treatment we will do for Pseudomonas aeruginosa. Antibiotic treatment is continued for 6 to 8 weeks, like that. Normally gentamicin combined with ticarcillin is given intravenously, but the thing is gentamicin is ototoxic and nephrotoxic, and ticarcillin may produce penicillin-like reactions. So we can also use third generation cephalosporins like ceftriaxone, which is given 1 to 2 grams per day IV, or ceftazidime, which is also given 1 to 2 grams per day IV. These two also can be used. And other things which can be used are quinolones or ciprofloxacin. Quinolones ciprofloxacin. Ciprofloxacin 750 mg once a day orally can be used. Then coming to the fungal infections, we have otomycosis. Otomycosis is because of the main fungal infections, three things, that is Aspergillus niger, Aspergillus fumigatus, Candida albicans. The clinical features in this otomycosis are intense itching, discomfort or pain in the ear, watery discharge will be there with the musty odor and ear blockage will be there. The fungal mass may appear white, brown or black depending on the infective organism. Okay. When you see it under otoscope, Aspergillus niger, if it is there, it appears as black-headed filamentous growth. If it is Aspergillus fumigatus, there is pale blue or green colored growth. Candida, if it is there, then it is white or creamy deposits will be there. It is treated by giving nystatin, that is 1 lakh units per ml of propylene glycol. This is given, which is given nystatin. Nystatin 1 lakh units per ml of propylene glycol. It is mostly effective against the candida. And then we use other broad spectrum antifungal agents like clotrimazole, povidone iodine, etc. 2% of salicylic acid in alcohol is also effective. Bacterial infections are often associated with otomycosis, and it is treated with antibiotic steroid preparations. Then coming to the reactive, we have till now discussed about the infective group of inflammatory disorders in ear canal. Now coming to the reactive group, we have eczematis otitis externa. It is because of the hypersensitivity to infective organisms or topical ear drops like chloromycetin or neomycin. This is most common in the people who use hearing aids like that. Then coming to the seborrheic otitis externa, it is associated with seborrheic dermatitis of scalp normally. So greasy yellow scales are present in the external canal, and we treat it by oral toilet and cream containing salicylic acid and sulfur. And we treat the seborrhea of scalp. Then coming to the neurodermatitis, it is caused by compulsive scratching due to psychological factors. Normally, when there is scratching, there can be damage to the ear canal, and it can cause secondary infections. Coming to the next things, tumors we have already discussed it along with the pinna tumors. Now coming to the miscellaneous conditions. In miscellaneous conditions, we have impacted wax or cerumen, foreign bodies in the ear, keratosis obturans, primary cholesteatoma of external auditory canal, acquired atresia and stenosis of meatus. All of these are there under miscellaneous conditions. Now, firstly, coming to the impacted wax or cerumen. Wax is normally composed of secretions from sebaceous gland, ceruminous gland, hair, desquamated epithelial debris, keratin, dirt. In some people few people sweat more than the others, so the activity of ceruminous glands will vary according to a person. Okay. Certain factors like narrow or tortuous ear canal, stiff hair or obstructive lesions of the canal, example exostosis and osteoma, can favor retention of wax. If there is retention of wax, it will dry up and form a hard impacted mass. So there is impairment of hearing, tinnitus, giddiness, reflex cough due to stimulation of auricular branch of vagus nerve, which is Arnold's nerve, and it can also lead to wax granuloma, where it is because of long-standing impacted wax, which causes ulceration of the meatal skin and result in granuloma formation. It is normally treated by syringing or instrumental manipulation normally. Sometimes a quiescent quiescent otitis media may be reactivated by syringing. Inactive stage of otitis media can be reactivated by syringing. And in instrumental manipulation is done often by Jabs and Horn prop, and occasionally if the wax is too hard and impacted, then we'll instill 5% sodium bicarbonate and equal parts of glycerine and water 2 or 3 times a day for a few days. Then we'll do it. Hydrogen peroxide, liquid paraffin or olive oil may also be helpful in this. Then coming to the foreign bodies of ear, the foreign bodies can be non-living like paper, sponge, grain seeds, slate pencil, piece of chalk. Mostly it happens in kids basically. Then or it can be living. The non-living foreign bodies can be removed by forceps removal or syringing or suction, microscopic removal with special instruments or post-oral approach. Coming to the living foreign bodies, we have crawling insects like mosquitoes. It is the crawling inside can be killed by instilling oil, which is a household remedy, and it can also be killed by spirit or chloroform water installation. There sometimes can be maggots of the ear in the ear because of eggs that are being laid by flies in the ear canal. They get attracted basically to the smelling ear discharge, and they lay eggs there and hatch it out, larvae called maggots. Then coming to the keratosis obturans. After foreign body infection, we have keratosis obturans. It is the collection of pearly white mass of desquamated epithelial cells in the deep meatus, and by pressure effects it can cause absorption of bone leading to widening of meatus. So there can be facial nerve that get exposed and paralyzed in this condition. It may sometimes be associated with bronchiectasis, chronic sinusitis like that. And coming to the clinical features of this, there is pain in the ear, hearing loss, tinnitus, and sometimes ear discharge. Removal of this mass may show widening of bony meatus with ulceration and even granuloma formation normally. Treatment, it is treated by removal by syringing or instrumentation. The recurrence can be checked to some extent by keratolytic agent such as 2% salicylic acid and alcohol. Coming to the primary cholesteatoma of external auditory canal, in contrast to the middle ear cholesteatoma, we have squamous epithelium in this of external auditory canal invading its bone. Okay, it might be post-traumatic or post-surgical. It is focal in contrast to diffuse process in keratosis obturans, and the clinical features include purulent otorrhea, pain, and tympanic membrane being normal. There is no abnormality in the tympanic membrane. There might be surgery required if in case of recalcitrant cases, and consists of removal. It normally consists of removal of cholesteatoma matrix followed by lining the defect with fascia or reepithelialization. Coming to the acquired atresia stenosis of meatus, it normally results from infections like chronic otitis externa, which is an important cause, trauma or burns. It is treated by meatoplasty. Now coming to the diseases of tympanic membrane, we have finished diseases of pinna and diseases of external auditory canal along with their tumors. Now coming to the tympanic membrane, first we'll see about normal tympanic membrane. How will it be there? It is a shiny pearly white grey in color with concavity on its lateral side and lateral surface more marked at the tip of malleus. And it is called that marked tip of malleus is called umbo. There is a bright cone of light seen in the antero-inferior quadrant, and attic lies above the lateral process of malleus, and it is slightly pinkish. And coming to the diseases of tympanic membrane, here in this diseases we have retracted tympanic membrane, meningitis bullosa, herpes zoster oticus, meningitis granulosa, traumatic rupture, atropic tympanic membrane, retraction pockets or atelectasis, tympanosclerosis, and perforations. Coming to the retracted tympanic membrane, if the tympanic membrane is retracted because of the negative pressure, negative intratympanic pressure, because due to eustachian tube block, the tympanic membrane becomes dull and lustreless. Remember the points that I'm saying here. The characteristics of retracted tympanic membrane includes it becomes dull and lusterless, and the cone of light will be absent or interrupted. Handle of malleus appears foreshortened, lateral process of the malleus becomes more prominent. Anterior and posterior malleolar folds become sickle shaped. Okay. Then going to the meningitis bullosa, it is otitis externa hemorrhagica. It is also called otitis externa hemorrhagica. It is a painful condition characterized by formation of hemorrhagic blebs on the tympanic membrane. It is normally caused by a virus called Mycoplasma pneumoniae. Then coming to the herpes zoster oticus, it is of viral infection involving geniculate ganglion of facial nerve. Just remember that. And coming to the meningitis granulosa, we have non-specific granulations formed on the outer surface of tympanic membrane in this. That's it. Coming to the traumatic rupture. The rupture of tympanic membrane because of trauma can happen due to these four causes. Trauma due to hairpin or matchstick unskilled attempts to remove a foreign body, or sudden change in air pressure where it happens like a slap or a kiss on the ear, or a sudden blast. Okay. It can also happen in forceful Valsalva may rupture it if the membrane is thin and atropic. And it can also happen because of pressure by fluid column, like if the person is diving water sports, forceful syringing can cause it, sea waves can cause it, etc. like that. And also it can be caused by fracture of temporal bone. Then coming to the treatment of it, edges of the perforation or reposition and splintered basically. And in in few cases, urgent exploration may be required. If there is vertigo and nystagmus, subluxation of stapes present, facial paralysis if it is present, then it requires urgent exploration. Coming to the atropic tympanic membrane, a normal tympanic membrane consists of outer epithelial, middle fibrous, and inner mucosal layers. In serous otitis media, the middle fibrous layer gets absorbed, leaving a thin drum head which easily gets collapsed with eustachian tube insufficiency. So this is atropic tympanic membrane. And coming to the retraction pockets or atelectasis, when the tympanic membrane is thin and atropic, a segment of it or the entire membrane may collapse inward due to eustachian tube insufficiency. It may form retraction pocket or get plastered onto the promontory and wrap around the ossicles. A deep retraction pocket may accumulate keratin debris and form a cholesteatoma there as well. Then the next condition is tympanosclerosis. It is frequently seen in cases of serous otitis media as a complication of ventilation tube. Tympanosclerosis is nothing but hardening of tympanic membrane, like calcification, hyalinization and lateral calcification of fibrous layer of tympanic membrane. Then coming to the perforations can be central, atic or marginal perforations, and these perforations are normally associated with chronic otitis media. And with that, we have completed all the diseases of external ear, that is pinna, external auditory canal, and tympanic membrane.